Repeat gentle pulling until catheter. Tip is fully out of the vein. Continue withdrawing the catheter in 1 centimeter increments using sterile technique until the entire catheter tip exits the vein. Confirm catheter tip integrity with a second nurse. Inspect the catheter visually to ensure it is intact and undamaged. A second licensed nurse must verify catheter integrity and co-sign if required by policy. Clean the insertion site. Again, use a sterile swab stick or appropriate antiseptic to clean the insertion site thoroughly. Apply compression with dry gauze. If bleeding occurs, use gentle pressure with sterile dry gauze to control any bleeding. Maintain pressure as needed based on the infant's condition and the site. Apply occlusive dressing. Place a small piece of petroleum gauze over the site to help seal the wound. Cover with a transparent occlusive dressing, e.g., Tegaderm, to protect the site. Confirm catheter tip integrity. Again, with second nurse, re-verify and double-check the catheter tip before disposal. Both nurses should confirm that the entire catheter is present and intact. Label the dressing site and instruct for follow-up. Clearly label the site with date and time of catheter removal. Instruct the bedside RN to reassess the site after 24 hours and remove the dressing if appropriate. Document the procedure. Record the exact time of removal in the EPICC chart. Complete the central venous line insertion record under the LDA, Lines, Drains, Airways tab. Include the names of both verifying nurses and note any complications. Special consideration: rapid or forceful removal can cause the catheter to bunch, increasing friction that may generate heat, potentially leading to catheter damage or holes. Always remove the catheter slowly and steadily in small measured increments. PICC Removal Smart Phase is assigned to each of you by the end of this class. What to document it, type of dressing, and other securement, such as StatLock infant tolerance of procedure, site inspection-related complications, action taken, name of individual assessing complications, document on expiration date. Continuous regular monitoring and documentation of catheter tip location to avoid complication is vital to maintaining enclampsia bundle prevention, including catheter tip location and monitoring guidelines. The FDA recommends radiographic confirmation of catheter tip placement. While a specific definition is not provided, best practice suggests that the catheter tip should be identifiable on all X-rays taken for any clinical purpose. Tip confirmation is also recommended. When clinical complications occur that may be catheter-related, new or worsening respiratory or cardiovascular distress, localized or unusual edema. With infant growth, as tip position may shift with increasing body length or weight, the entire circumference of the infant's extremity should be visualized from above the insertion site to the catheter hub to ensure full coverage and detect any external issues. PICC complications, cardiac tamponade. Now let's take a moment to talk about one of the most serious, but thankfully rare, complications associated with PICC lines: cardiac tamponade. What is cardiac tamponade? Cardiac tamponade is a life-threatening condition that occurs when fluid builds up in the pericardial space, compressing the heart and preventing it from functioning effectively. In neonates, this can happen if the PICC tip migrates too far into the heart or perforates a vessel wall. Prevention is critical. The best way to prevent this complication is through careful placement and confirmation of PICC line tip position. Key prevention point: always ensure that the tip of the PICC is clearly visualized outside the cardiac silhouette on radiographic imaging. This means we should never accept an unclear or borderline image. If the tip appears to be in or near the heart, repositioning is required before using the line. Warning signs of possible tamponade. As caregivers, it's our responsibility to be alert and responsive to the subtle but serious warning signs. In neonates, these may include tachycardia, an early compensatory response bradycardia, which may follow as the situation worsens hypotension desaturation, a drop in oxygen levels, muffled or quiet heart sounds, which may be noticed during auscultation, sudden collapse, or cardiovascular instability, and radiologically, an enlarged cardiac silhouette on X-ray. If any of these signs appear, stop infusion immediately, notify the provider, and be prepared for emergency interventions. Final thoughts. Always remember, accurate line placement, regular reassessment, and early recognition of symptoms are our best tools in preventing this life-threatening complication. Cardiac dysrhythmias related to PICC line placement monitoring. During PICC insertion in the NICU standard monitoring. During PICC line insertion, most NICUs continuously monitor heart rate, respiratory rate, oxygen saturation alarm. Triggers monitors typically alarm for bradycardia, tachycardia, other dysrhythmias. Limitations. Monitors may not detect or alarm for premature atrial or ventricular contractions, PACs or PVCs. These may indicate catheter tip irritation if the line has migrated into or near the right atrium. Another complication, catheter embolism. Shearing of the catheter may not be immediately detectable during insertion. A catheter fracture can progress to complete shearing over time while the catheter is indwelling. Signs and symptoms: tachycardia, tachypnea, increased respiratory distress, hypotension, altered level of consciousness. If a fracture occurs, fluid leakage from the insertion site may be observed, and swelling along the vein tract may develop. And what about air embolism risk in neonatal PICC? Due to the small internal diameter and length of the neonatal PICC, the resistance to flow is high, making this complication highly unlikely. Signs of an air embolism: respiratory distress, hypoxia, tachycardia, bradycardia, hypotension, altered level of consciousness. Let's take a moment to review an important but sometimes overlooked complication associated with PICC lines: nerve irritation or damage. This issue has been primarily reported in adult patients, with symptoms such as numbness, tingling, or weakness noted either during or after the procedure. So, what causes this? There are three key culprits. First, direct damage from the needle during venipuncture. Second, nerve irritation that can occur during catheter advancement. And finally, attempting to advance a catheter that is not fully within the vein, also known as extravascular placement. How can we prevent this? Always aim to insert the catheter into the vein with minimal probing. Confirm that the catheter is fully within the vein before you proceed with advancement. And what should we do if nerve irritation or damage is suspected? Stop the insertion immediately. Monitor the position of the introducer. Evaluate the patient's symptoms and consult appropriate support if symptoms persist. Keeping these steps in mind helps us reduce complications and protect our patient's safety during vascular access procedures. Now, let's review some key points for PICC line assessment and documentation, a vital part of each nursing shift to ensure patient safety and line integrity. Shift assessment. At the start of every shift, you'll want to perform a thorough assessment of the catheter insertion site, the surrounding tissue, the vein tract, and the catheter tip. You're looking for any signs of complications or changes since the last assessment. Let's break this down. Vein. Palpate gently along the vein tract. Any pain or tenderness here could be an early sign of phlebitis. Always take reports of discomfort seriously and document findings clearly. Catheter. Check for any external kinking, leaking, or changes in the external catheter length. These may suggest movement or malposition. Before administering medications, perform a flush to confirm patency, aspirating for blood return when appropriate. This also confirms that the catheter is still in the vascular space. Dressing. Inspect the dressing. The outer border and the site covering must be securely adhered to both the catheter and the skin. If you see lifting or soiling, it's time for a dressing change per protocol. Infusion pump. Take a look at the occlusion alarm settings. These should be appropriate for the catheter's size and material, based on your hospital's guidelines. Incorrect settings could delay detection of a blockage or mislead you during troubleshooting. IV tubing. All connections should be securely luer locked. Inspect the tubing for any signs of precipitate formation or leaks. Both are potential safety concerns. Tip location complications. Be aware that the location of the catheter tip can influence the type of complications we might see. For instance, a subclavian tip placement might lead to vein erosion. This could present as shoulder swelling, redness. Next, hourly assessment. Documentation. Both shift and hourly assessments should be accurately recorded in the nursing documentation. Insertion site. Visually inspect the catheter insertion site, tracking along the vein and assessing the tip location. Catheter monitor for any signs of kinking or leaking. Infusion pump. Check the quantity of fluid infused and verify the pump's occlusion alarm setting. External visible length measure and document the length of the catheter that remains outside the insertion site.